Thank you so much. And I would like to thank AIOS and Professor Atul Kumar for the kind invitation to be a part of the ASRS Symposium. Wish we could have been with you in person today, but this is a fantastic virtual platform that's been organized by AIOS. So over the next 10 minutes, I just wanted to talk about some of the techniques that we've used for refractory macular holes. As we are all aware, macular hole repair has really been one of our most successful surgeries that we perform as vitreoretinal surgeons. And ever since Kelly and Wendell proposed a surgical closure of macular holes, it's really taken off and evolved. And in that original paper is one of the 100 most frequently cited articles in all of ophthalmology. So there are a lot of approaches, as I'm sure you're aware, for refractory macular holes, and we could probably spend better half of a day talking about them. But over the next 10 minutes, I'm going to primarily focus on more of a plug and scaffold-based approaches rather than ILM-based approaches. So we'll not be discussing inverted, autologous, or retractable door ILM flaps, but rather focus on autologous blood or platelet-rich plasma, macular detachments with subretinal blebs, the autologous retinal transplant, and the human amniotic membrane graft. There's also a lens capsular flap that has been described. I have no personal experience with this, so we won't be covering that in this particular talk. So as you know, Professor Rizzo described the use of the amniotic membrane graft as a plug to close both macular holes as well as some associated macular hole retinal detachments, and even for peripheral retinal breaks. There are various types of amniotic membrane that are available, and these of course differ in the region, but some of the ones that we use here are a cryopreserved amniotic membrane that varies in thickness between 50 to 100 microns, and then two variants of a dehydrated amniotic membrane, one that is about 35 microns and the other one that is thicker at about 50 to 100 microns. And in general, these are composed of an inner compact layer that is comprised of the cuboidal epithelium, which has a thick basement membrane, and the stroma, and this is really the sticky side. And then there's a middle fibroblast layer and outermost spongy layer. So the key in these kinds of surgeries is, as with any refractory macular hole, you do want to confirm adequate removal of the internal limiting membrane. So with the use of dye of your choice and then instruments of your choice, you do want to inspect and confirm that any residual ILM and ERM have been removed, paying particular attention to any fibrotic rings around the macular hole. So we generally use a 1 millimeter derm punch to create a circular ring of the amniotic membrane, and then carefully remove it, and then using a 25 or 23 gauge trocar system, insert it into the vitreous cavity. Now, the key when you're placing the amniotic membrane is you would like to get it in the subretinal space rather than just sitting on top of the macular hole, because that is more subject to displacement. Once you have inserted this into the macular hole, and you sometimes may need to resize this for smaller holes, although refractory holes in general are on the larger size. If you need to resize it, it can be done with the use of intraocular horizontal scissors inside the vitreous cavity as well. After the disc is placed, then you perform gentle fluid air exchange, and this is followed then by the tamponade of your choice. Usually short-acting to sometimes C3F8 gas would be adequate in these cases. And then post-operatively, this is what you would like your OCT to look like, with this hyperreflective amniotic membrane sitting in the subretinal space and the macular hole closed. Now, the limiting factor here is, of course, the regeneration and the potential for regeneration of the outer retinal cells. And that is something that we are still waiting to see how much improvement in visual acuity is possible beyond that just attained by the closure of the macular hole and reduction in scotoma. In some cases, particularly high myopes where there's a lot of chorioretinal atrophy, it may be difficult to see the amniotic membrane. And in such cases, staining it with trypan blue is helpful, as you can see here. And particularly if you're using the 3D visualization system, like Professor Kumar is going to talk about, you can really use the filters to highlight the amniotic membrane quite well intraocularly. Now, it's important that you are looking for a configuration where the amniotic membrane is in the subretinal space post-operatively. And there have been electrophysiologic studies as well that have demonstrated an improved amplitude in such cases. When you're considering a plug-based approach, the key differences to recognize between the autologous retinal transplant and the amniotic membrane graft. One of the issues is that with the autologous retinal transplant, we do see flap integration with linking of the neurosensory layers, not in every case, but in several cases. And secondly, manipulation of the retinal graft under perfluorocarbon is easier than the amniotic membrane. With the amniotic membrane, one of the challenges is to identify the chorion layer as the sticky side of the plug. And also a key advantage of the amniotic membrane is in cases where there is prior extensive laser or chorioretinal scarring, it's much easier to obtain the amniotic membrane. You also want to tailor your approaches for cases with have a macular hole associated retinal detachment, whether you want to consider doing a staged procedure where you fix the detachment first in the hole at a second time, or you perform a combined surgery with a plug-based approach at the same time. It's also important to recognize that in high myopes, there are some reports of progressive atrophy after the placement of the amniotic membrane, and it's important to monitor for this. Again, the author suggested that adequate placement in the subretinal space would help mitigate this. Another approach is autologous blood or platelet-rich plasma. We're all familiar with what platelet-rich plasma is, which is basically the buffy coat. This is a good source of growth factors, cell adhesion molecules, and it also provides a temporary scaffold. The technique itself has been used over the last several decades, and it's quite straightforward in terms of harvesting blood, whole blood from the antecubital vein, spinning it down for about 15 minutes, and then extracting the supernatant. It's important to recognize that it has to be used within 15 minutes of preparation, so you want to do it at the appropriate stage in the surgery. So you can see here, this is a large macular hole with an associated localized retinal detachment. And then during the surgery, again, after you remove the epiretinal membranes, you've performed your fluid air exchange and then drainage of subretinal fluid, you're instilling 3 drops of this freshly prepared platelet-rich plasma. And that is followed by silicone installation. It's important to recognize that if you are using intraoperative imaging, this is what you want your plug to look like, with the platelet-rich plasma forming this coagulum rapidly. This is this hyperreflective fibrin plug that is plugging the macular hole. This is how you should look like post-operatively. The ideal configurations will demonstrate a gradual absorption of that plug over the period of about 4 to 6 weeks, and you do want it to be extending into somewhat into the subretinal space, but certainly plugging the macular hole. This is what you do not want to see post-operatively when you're applying whole blood or platelet-rich plasma, which is basically a space between the neurosensory retina and the plug, which occurs because of inadequate drying of the retina. It's important to pay attention to this in high myopes with this posterior staphyloma, where there may be reaccumulation of fluid. So again, patient drying is critical before you apply blood or platelet-rich plasma. Then the autologous retinal transplant, and I was very fortunate to be involved with Dr. Tamer Mahmood for the development of this technique. And we have refined it to the point that it's more streamlined now. So in general, you would want to identify a site superiorly to harvest the graft. This is followed by filling the eye with perfluorocarbon that extends beyond the anterior margin of the harvest site. And then using your vertical scissors, pneumatic or manual, we are performing a harvest of the graft site, extending across the diathermy margins. This is then followed by applying laser barricade about 2 to 3 rows around the harvest site, and recognizing that all of these maneuvers are being performed under perfluorocarbon. And the advantage of doing that is that once your harvest is complete, you can use a forceps and then just slide this graft across the posterior pole and center it in over the macular hole. This is a key advantage because you maintain orientation of the graft, and you are also able to position it much easier over the macular hole under perfluorocarbon. And at the conclusion, this is followed either by a direct exchange, or you can also leave a short-term perfluorocarbon tamponade in for 1 to 2 weeks and then remove it. The overall closure rate is about 90%, and it's over 95% in eyes with macular hole retinal detachment. About 40% of eyes gain at least 3 lines, 30% gain at least 5 lines, and 12% actually ended up with 20/50 or better vision. The final visual outcome depends on reconstitution of the outer retinal layers, as well as the alignment of the neurosensory retinal layers, and that is really a key feature of the autologous retinal transplant. And these kinds of anatomical results and range of visual gains have now been reported by several authors. And this is what you're hoping to see post-operatively. And you can see here that you can see alignment of the inner layers of the retina. And then finally, a brief video, and this is Kosten-Myers technique. This video was provided by my colleague, Leila Bajzovic, in which they're using subretinal blebs. So you place a little bubble of perfluorocarbon to cover the fovea so as to prevent migration through the fovea. And then you're using this 41 gauge cannula, and you can just place it on top of the neosensory retina in areas where the ILM has been removed to create multiple subretinal blebs. And that is followed at the end by mobilizing the retina using a finesse loop or a tunnel scraper, and then a fluid air exchange. And this technique also works quite well to achieve closure. So in general, there are several different techniques available. I think it's important to recognize that you adopt a technique that works for you, because there is a learning curve with all of these. Done well, most of these techniques have good outcomes. Thank you very much for your attention.